Welcome to another episode of eHealth Matters. I'm Aisana, clinical lead for eSurgery, and today I'm joined by Dr. Charlotte Dodd. Charlotte, welcome. Would you like to introduce yourself?
Yep, so I'm Charlotte. I am a doctor who specialises in women's health, have done for a number of years, and I am in particular fascinated by the menopause, which is what I'm coming to talk about today.
It's a really, really important topic. It's not something that it's talked about as much as we would like it to be talked about. So why are we here? Why are we discussing menopause? Why is it so important?
So I think that's a really great question. So menopause affects around 50% of the population. And there's currently is about 13 million people in the UK that's currently going through the menopause. And that includes perimenopause, going through the menopause transition, or postmenopausal. And actually you spend a third of your life postmenopausal. So it's a really important stage in your life that you go through. It's important for me to educate others. I think there's a lot of misinformation out there, and there's a lot of horror stories that you can have. And even if you're not going to go through it directly, you will know someone who's going to go through it, whether that's colleagues, whether that's friends or family members. And it's really important to be able to get the right support for those people.
Amazing. Thank you. So there was a lot of words referring to menopause.
Yes.
And obviously it's the topic. So tell me, what is menopause? You refer to perimenopause and premenopause and actual menopause. Just tell me what each of them actually means.
Typically, menopause happens around the age of 51 in the UK. And it happens when you stop having periods for around a year. When you are around 45 to 55, your hormones start to be more erratic. And at that point, you have changes in your symptoms and changes in your periods. And that's what we call the perimenopause. Before the age of that, so around kind of 45 or less, that tends to be premenopausal. So you don't have any symptoms, your periods are regular or your cycles are regular. And then postmenopausal is when you've finished your periods onwards. So normally that's typically from the age of 55 onwards.
So basically it's 1 year of not having any menstrual bleeding, and you will be considered menopausal.
Yes, so postmenopausal after that, so that means you're not able to have any more children.
Okay, so are there different types of menopause? Does it naturally happen to us, or does it, do you have to have a kind of a surgical intervention? No,
so menopause naturally happens to every person who's born with ovaries. So it will happen inevitably, and that's called the natural menopause. You can have certain situations where that happens at different times. So, and you can have a natural menopause that happens earlier. So if you're around the age of 40 to 45, that's what's classed as an early menopause. Right. But under the age of 40, that's classed as a premature menopause, and that's also known as premature ovarian insufficiency, which sounds like a very scary term, but basically it means that your ovaries aren't working as they should do a lot earlier. You can also have kind of unnatural causes of the menopause, so that's things like surgery or medications. Again, these can happen at any point during your kind of reproductive life. So you can have surgery for different gynecological conditions, which then will have an impact on your menopause. So for example, having your ovaries removed or having your womb removed, or called a hysterectomy. So they're surgical methods. You can also have medical kind of management as well. So that's things like chemotherapy sometimes can affect how you experience menopause. In addition to, if you have conditions like endometriosis, that we induce a menopause in those patients so they no longer have those symptoms, they don't have the pain, and they don't have the heavy bleeding anymore.
Okay, that's really interesting. So, it can literally happen at any stage of the life to any of us.
Yes.
And we eventually will go through it as well.
Yes.
It's a bit scary, isn't it?
It can be scary, but I think, and a lot of people, there is so much misinformation, so many horror stories, that actually it is an inevitable process.
Yeah.
And we're kind of, I would like to empower women to have that knowledge, to know exactly what is happening to their body. And it's nothing to be scared of. It's completely normal, but there are things that can help.
Yeah. I think it's something that myself and probably most of kind of my relatives, friends that I've ever discussed kind of menopause, we're almost terrified of reaching that stage. As you said, it's such a taboo thing as well. And we need to kind of just get rid of that stigma and change the narrative, right?
Yes.
Okay.
Yeah, definitely. I think there's so much stigma about menopause. There's so much unknown about female health anyway. And in particular, there's very limited research and very limited funding into what happens in the menopause, which is a real shame because, like I say, it does happen to pretty much half of the population, and you will spend your life postmenopausal. Yeah. So it's really important that we are able to kind of understand what happens, why it happens, and therefore, because of that, then how we can help those women who suffer from those symptoms.
Yeah, no, that's very, very true. Let's just kind of recap, and if you could kind of help me have a better understanding of, from the moment that we are born as women, as females, what happens to our physiology? What do we go through that eventually leads to this stage of our life, which is menopause?
Okay. So I like to think of it as menopause is a bookend for your reproductive life. So at one end, you've got puberty, which is the start of your reproductive life, all the way through to menopause, which is the end. So when we are born, if you're born with ovaries, you are born with all the eggs that you're ever going to have, which is around 1 to 2 million eggs. By the time you reach puberty, that is a lot less, it's about 100,000. Right. And when you hit puberty, what happens is that is when you start your periods. But how that works is that you have hormones that are released from the brain. They then go to your ovaries and your uterus to switch them on, essentially, to get ready for a pregnancy. So those hormones include the most kind of well-known ones are estrogen and progesterone. Right. So with estrogen, that helps prepare the egg ready for a pregnancy, but also the progesterone helps thicken the lining of the womb and again ready for implantation for a pregnancy. So when you start your menstrual cycle, you release an egg. That egg hopefully would meet a sperm and fertilize, and that would result in a pregnancy. If that is a pregnancy, then it will implant into the lining of the womb, which is nice and thick and juicy, ready for the kind of a good healthy pregnancy. And if that doesn't happen, then that line of the womb sheds every month, and that's what is a menstrual period. That happens again and again and again until you stop having any more eggs.
Do you literally just run out of stock?
Yes.
That's it. That's like finished.
Yeah.
Okay. That's really interesting. I always assumed it would be low amounts of eggs, but like you literally run out of eggs.
Yeah. So normally, in your 30s, you're probably down to about 10% of the eggs that you had when you started puberty. And those eggs are normally low in number, but also low in quality. So they're less likely to result in a pregnancy or a healthy pregnancy. So when you are more towards the menopause, the hormone levels change because of the quality and the number of those eggs. And therefore, with that, then you have symptoms of menopause.
That's really interesting. I feel like I'm going to get kind of sidetracked by a different topic by exploring this a little bit more. But let's say you are getting closer to the 40 age mark. Are there kind of blood tests to say how long you've got left till you reach your menopause?
So there are loads of blood tests that you can do. The problem with blood tests is that they are, your hormone levels fluctuate all the time. So that if I took, for example, your blood one day and I took it again next week, it could be completely different. And therefore I would have no idea where you would be in your cycle or how many eggs you would have left. We don't tend to test, as clinicians, we don't tend to test for menopause unless you're under the age of 45. But if you're between 45 and 55, you have symptoms of the menopause, it's likely that you're kind of perimenopausal going through the menopause. So we don't tend to test for that. Right. The only thing we do test for are things that mimic the menopause. So things like hypothyroidism or problems with kind of vitamin levels like vitamin B12, vitamin D, in which case then we would test for those to rule them out and get you the right support. But on the whole, particularly if you're around that age, we don't tend to test for the menopause.
That's interesting. And when you do test for the to have a blood test, are we looking at estrogen and progesterone levels, or are they different types of hormones that we're looking at?
It's normally different type of hormones. So it's normally things like what we call FSH and LH, which is follicle stimulating hormone or luteinizing hormone, and they help prepare the eggs. There's another hormone called anti-Müllerian hormone, which it's meant to look at the amount of follicles that you have left, but it's quite unreliable. And again, we don't really test for it. Unless you were perhaps having an early or premature menopause.
Okay, that's really interesting. So don't bother getting a kind of blood test. It's not going to really help. It's not going to tell you any much more than just having a conversation with your healthcare professional.
And I think if you're going through those symptoms around that age, I think you have to listen to your body. Your body's trying to tell you, okay, this might be a change there.
That's interesting. Thank you very much for that. So what are the symptoms of menopause? I think one of the things that we always hear is hot flushes. That is one of the most common ones, but I'm sure there is a whole long list of menopausal symptoms.
That's right. There are around 30 menopausal symptoms or even more. They're kind of most recognised. And around kind of 3/4 of people who go through the menopause will have symptoms, and 1/4 of those will be debilitated by them. And it's really important to know that actually you have estrogen, and estrogen is the main hormone related to kind of problems or symptoms in the menopause. You have estrogen receptors in pretty much every organ system in your body, so it affects pretty much everything. And you're very used to have it when you're kind of premenopausal. You're used to having lots of estrogen. So when you don't have estrogen, those organ systems start to change. So the most common symptoms does tend to be hot flushes and night sweats, which happen to about 75% of people, and that is the one that causes the most distress. There are other symptoms as well. So trouble sleeping is a huge one. A lot of people don't realise that is a symptom of the menopause, but it definitely is. And that again is affected by things like night sweats, if you've got a decrease in your mood or change in your mood, but also kind of all the stresses in your life. Again, they can all play a part in problem sleeping. Things like changes to your skin and your hair, changes to your joints, so you can get joint pain. There's another one, and achy joints. You can have problems with vaginal symptoms or urinary symptoms, so you can get vaginal dryness or itching. You can also get kind of symptoms of UTIs or urinary tract infections, and urgency as well, that you need to go to the toilet more often. The other one is kind of mood changes and changes in libido. So mood changes is a really interesting one. So around 70% of people will report mood changes, but again, it's not necessarily related to the menopause, or they don't think it's related to the menopause. It's more to do with life stresses. You know, you're taking care of your kids, you're taking care of your parents, you've got work stress, all that kind of stuff. So that can change mood. And again, kind of sex changes as well. So you often have a loss of interest in sex. And again, that affects about 50% of women, which is a massive thing that isn't reported, it isn't talked about, but it can be a huge stress on their relationship. And I think in terms of their symptoms, a lot of these we're just kind of guessing as the kind of amounts of people that are suffering from them, because we don't really know.
Okay. I'm just trying to digest this. Is a lot of symptoms one might go through. Absolutely, there's actually quite a lot. And I'm just trying to think, so let's say I'm going through some of these symptoms, I'll go and see my GP. And I've heard kind of so many stories where patients have referred to their kind of GP, and they either have come out with antibiotics for UTIs or antidepressants because they think that they've got depression. So what I'm trying to say is that a lot of these symptoms can be overlapping with other health conditions. How does one kind of get the help that they actually need without getting dismissed when they have those conversations to say, actually, we need to dig deeper into your symptoms. This is not just signs of depression or a frequent UTI, urine infection. What would you recommend?
I think you're definitely right. I think a lot of women either don't recognise it in themselves, which is right. And particularly education about symptoms and what is normal, typical for the menopause, is so important. But also, healthcare professionals often aren't well educated in menopause and menopausal symptoms and how to help. So we know that if you do go to the GP or healthcare professional, only around 45% of women will actually go with these symptoms. And when they do go, we know that a proportion of those will not either be believed, or they won't necessarily be treated, that they are kind of in that menopause transition. It is important to say that, you may have symptoms of depression, you may have symptoms of hypothyroidism, low thyroid hormone, and those things need to be ruled out and those things need to be treated correctly. However, you have to look at the patient as a whole. What has changed? What has happened? What is their age? Where are they in their family life? All of those things kind of point towards whether this could be menopause or not. And it's always worth thinking in the back of your head, could this be something like that? So it's really important if you do go and see a GP or healthcare professional, that you keep a symptom diary, and ideally to say, what symptoms you're having, when, what have you tried for it, but also how is this affecting your quality of life, because it's all about how this is affecting you.
Yeah, no, that's really, really important. It's kind of almost, you don't want to put the pressure on the GP and be like, you're misdiagnosing patients, because, I mean, to be fair, they've got a 10-minute slot. And as you said, you have to look at the patient as a whole, right? Mm-hmm. And that's sometimes not achievable within a 10-minute time slot with the pressures that the GPs are currently facing. So probably not very fair to kind of put the blame on them. I'm sorry, GPs, if I'm doing that. You're doing a great job. However, it is also really, really important, as you said, to do as a patient, to have the awareness. As you said, maybe keep a diary, really kind of try and analyze what time of day, for example, you're experiencing these symptoms. Are you experiencing any other kind of drastic changes within your day-to-day lifestyle as well? Because day-to-day life pressures can also have an effect on us as a person, right?
Yeah.
And that they can contribute to our symptoms. So yeah, to look at it as a whole.
Definitely. I think you're right in the fact that actually, as women, we do tend to put things off, and we do tend to kind of be focused or be busy with other things.
Yeah.
And like I say, the generation that are going through the menopause, 45 to 55, they normally are taking care of the kids, or the kids are leaving home, and they have, a lot of pressure with their work life. They have an active social life, and they have relationships. So all of those things can actually impact on how they're feeling anyway, and can add to the kind of that stress level. But there will become a point where actually that isn't necessarily what's always going on. It's also their physiology as well.
Yeah, no, absolutely. So what are the long-term consequences of menopause? How is this going to affect us in the long term?
So as I already said, there are estrogen receptors in pretty much every organ system in your body. So your body is used to getting estrogen. When it doesn't get it, it does kind of look for different ways of getting it, or it just doesn't do as well without it. Yeah. So things that are at higher risk of having in the menopause, not necessarily will develop it, but definitely a higher risk of developing things like osteoporosis. And that's when your bones are less dense, so they get thinner. And so you're more at risk of kind of having fractures if you fall over. Things like cardiovascular disease, that's heart attacks, particularly in women, they present slightly differently. And so it's really important to be aware of those and kind of risk factors for those as well. Things like stroke and blood clots. The other big thing that happens during kind of that middle portion of your life is weight changes. So it's important to note that that is a normal physiological thing that happens. Mm-hmm. So a lot of women talk about having a spare tire, which is basically where they have a lot more weight around their waist. That's where they carry it more.
Yeah.
And that does change kind of as you get older. And there is a physiological reason for this. And that is because your estrogen levels changing, fat cells have more estrogen. So when you break down your fat cells, you produce more estrogen. So your body, who isn't now getting more estrogen or isn't used to that level of estrogen, tries to seek it out. So when you eat, then it turns more of your the food that food that you eat, it turns it more into fat cells, particularly around your middle, and therefore it should release more estrogen. So there is a reason why you do have that spare tire. Having said that, because it's kind of long-term risks, having that additional weight can cause things like type 2 diabetes, yep. More like to have high blood pressure, more like to have high cholesterol. So it's really important in that period of your life that you are doing things to kind of counteract those changes.
I see. Okay. So you don't necessarily should we expect to get at least one of these conditions?
No. So
I'm just like, oh my God, am I going to get all of these conditions as I get older?
I know. And it's a really scary thing to read about or to kind of talk about, because you think, all of these things are going to happen to me, and basically your body's just going to shut down. That's not true at all. Okay. There are lots of things that can happen. And like I say, it's a risk that these things happen, but it's not a definite, it's not a guarantee. And actually there are lots of things you can do before you reach that age, or even when you're at that age, that you can counteract those risks. So lifestyle measures, kind of losing weight, make sure you keep a healthy weight, those kind of things definitely will mitigate those risks.
I see. Okay. Let's talk about the things that we can do then.
Yes.
A little bit, you briefly just touched upon it as well. What can we do to kind of reduce these risks? One of the... I think my mom always said, make sure you drink your milk because as you get older, you will end up with osteoporosis. Us women always get osteoporosis. So I think there's this kind of old wives' tales.
Yes.
I don't know. Sometimes it's true, obviously.
Yeah, there is a seed of truth in that, actually. So when as we get older, we do, our metabolisms change, and your mum is right. So it's really important, particularly with diet, when diet's concerned, we eat things like less carbohydrates, because again, that can be converted into fat. But also we have a diet high in fiber, but also the calcium and vitamin D, and that the calcium and vitamin D is key to protect bone strength and bone health. So really important that that's addressed. Other things for bone health as well, things like exercise. So ideally we should all be doing 150 minutes of moderate physical activity a week. So that's about 30 minutes 5 times a week. And some of that should be weight bearing, again, to protect those joints.
Of course. Yeah.
Other things that we can do. So we've kind of talked about diet and exercise, but actually maintaining that healthy weight. So if you maintain a healthy BMI, so that's normally a BMI less than 25, it not only reduces the symptoms you will get from menopause, but it also reduces all of the kind of risks that we will talk about, those long-term consequences. Those things like type 2 diabetes, but in particular things like all the different types of cancers. Generally in the future, you're massively at risk of if you're overweight. Other things like stopping smoking, really key. I mean, smoking is absolutely. You'll always be told. You'll always be told not to smoke. But even kind of vaping and things like that, it's really not very good for you. It increases your cardiovascular risk, and also it will increase the amount of symptoms you have and the severity of your symptoms of menopause, particularly those kind of hot flushes. And the same with alcohol. So a lot of people, again, don't tend to think too much about alcohol and how much they consume, but it has a massive effect on all types of cancers, particularly breast cancer. So if you drink a moderate to high amount of alcohol, it massively increases your risk of breast cancer, but it also increases the severity of the symptoms you will get. So all of those things that we can think for lifestyle-wise is really key. The other things I haven't talked about are the things that are harder to kind of manage, and that's stress management and sleep. So sleep hygiene is key, and we should be going to bed at the same time each night, no kind of screens, and we should have a relaxing routine, all those things. But also with the kind of stress management, it's very easy for me to sit here and say, don't have a stress.
Don't have a stress.
But actually it's really hard in practice. So all those things can help with those symptoms as well.
When you say it can help, does it significantly reduce your symptoms?
Yes. So it's been proven that particularly stopping smoking, maintaining a healthy weight, so that's with diet and exercise normally, and reducing your alcohol, they have a huge impact on the severity of your symptoms for the menopause, but also those long-term risks.
Interesting. Obviously, we will talk about the kind of HRT and other treatments to manage symptoms of menopause. But would you say implementing these kind of the whole list of the lifestyle changes, would they affect or would they manage your symptoms on its own?
So that's a really good question. I think if you have any of those symptoms, I think it would always be good to try and maintain a healthy lifestyle, stop drinking, stop smoking, all of those things. And I think those, you can definitely see patients who have been overweight or have been smoking and they have symptoms. If they stop that, they do have a reduction. It's not going to be, it may not stop them completely, but it will definitely help. It's like an adjunct, right? And it's a good thing to do for long-term health as well.
Absolutely. Yeah.
The other thing that we can also do is about education. So for me, it's really important that people get the right education and the right knowledge about what's happening in their body, particularly regarding to the hormones and the. Because of that, then they get on the right treatment or they get on the right pathway to reducing the amount of symptoms that affect their quality of life.
Interesting. Where can people get help or information about how to manage their symptoms, or what would the next steps would be for them? I
think for me, I'd always say go and see a healthcare professional. So that's either their GP or a menopause specialist. I think it's really important that they get the right information and it's evidence-based. It's really scary going to GP sometimes, especially when you have that fear of not being believed. There's so much stigma around menopause and about aging women in particular, which is really frustrating. And it's really important that you're able to kind of seek that help. When you go to a GP, they might ask you lots of personal questions, particularly about sex lives and your bowel and your bladder and things like that, which again can be really off-putting. But actually, they're only there to help you, and they're not there to judge you at all. a lot of women go through this at some point in their lives, or all women go through this at some point in their lives. And so it's really important that GPs are aware, and they are very, very professional at kind of dealing with these kind of symptoms. The other thing is there's a vast knowledge from them to signpost you to the right resources. So things like the British Menopause Society, but also on the NHS website, there's lots of information about how the menopause can affect you and where to get further help from.
That makes sense. And I've also noticed that within workplaces, there's also lots of campaigns going on how to support women when they are going through these changes in their life as well. Because, growing up, even with the menstrual cycle that, as one goes through, I always wondered, why doesn't anyone take this into account? And it always kind of bothered me. Like, I'm in a lot of pain. There's lots of hormonal things going on. Like, this is actually affecting my concentration, my productivity. No one seems to talk about it. Within family setting as well, usually the kind of, whether it's your father figure or your brother or your husband, do they actually also know what you're going through as well? I think that's also really, really important to kind of address. That it's not just about us as females being educated, but it's also to educate everyone so that they can support us and have that understanding as well.
I think you're absolutely right. I think it's not just education for women or people that go through the menopause. It's actually for those people that support us as well. And we know that there are workplace champions, and a lot of workplaces now are kind of developing that awareness that actually menopause, you will still work when you have the menopause, you still go through. And actually a lot of people who experience kind of sickness or kind of absences when they are menopausal will lie about why they're not in work because of the stigma attached to menopause. So around kind of 40% of people won't actually say that they're menopausal on their sick note. It will be that, they're depressed or anything else. Yeah. So it's really important that we're aware of these changes, and then we make allowances for these women so they can continue on their work and they can continue, with their livelihood for their rest of their working life. Yeah,
no, that makes sense as well. And I suppose this is more than just addressing menopause. It's more of a society change and how things have changed. If you look back 50 years ago, this might be a little bit unfair to say, but majority of women weren't in, but they were the kind of the housewife type, right? So you weren't in a kind of workplace environment, and now majority of women are kind of in the similar positions, but nothing has changed. No. You still have the same expectations, but you don't have the support.
Exactly.
Well, hopefully the support is coming soon.
Yeah, exactly. And you do have those additional pressures, like being able to particularly women in higher power jobs, but any women who work, if they work in an environment where, particularly when there are different people or men involved and they don't quite understand what's happening, it is really scary for them. And all the other symptoms, things like, it's not just the hot flushes and things, but it's also the brain fog and the cognitive decline as well. Yeah. That really affects women, and you can often find that around 10% of women will actually leave their job during the menopause because of their menopausal symptoms, because they just feel like they can't cope. And those people sometimes don't even know they're going through the menopause. They just think it's part of getting older, or they think it's dementia related, which is not necessarily true. So it's really important we educate everyone about the symptoms of menopause and how we can support them.
So let's talk about treatment. What can we do other than the lifestyle changes that we talked about? What are there any medication that we can take?
Yeah, so as I've talked about kind of lifestyle measures, the other things that we can take are medications. So we know that there's a lot of evidence for lots of different types of medications. We tend to group them into hormone replacement therapy, or HRT, and the non-hormone replacement. So with those things, particularly with HRT, there's lots of different options with both. And we just, as healthcare professionals, when we're prescribing them, we look onto your symptoms, we look at your background, your lifestyle, and see which one may be best for you.
And do most women who seek HRT end up actually taking the HRT and staying on it as well?
So it's a really interesting question, actually. So around kind of 20 years ago, there was a big paper published, a lot of research, and it actually scared a lot of people off HRT because there was some evidence to suggest that it causes an increased risk in breast cancer. Now that is that's been debunked, and there is that although there are risks involved with taking HRT, actually, there are a lot of women who are not taking HRT at the moment that perhaps could benefit from it.
Yeah.
We know that only about 14% of people in the UK who are going through the menopause are actually on HRT. And we know that it should be offered at every healthcare professional visit. If you're going through symptoms of menopause and you're around 45 to 55, you should be offered HRT. But we know that doesn't happen. It happens about 40% of people.
And why is that? Why is such a low figure?
Because menopause is a really good mimic. A lot of people don't know the symptoms of menopause or don't necessarily attribute it to a natural process. A lot of people think there must be something wrong with me because I've got all of these symptoms. And actually, it's just a natural process.
Interesting.
So, and that's not necessarily just because of it's not on the patient, it's not on the woman. Yeah. It's also on healthcare professionals. They also don't always recognise it. They don't get very well trained on it. So like you say, 10-minute appointment, you've got a long list of problems. You won't necessarily think, that's the menopause.
That's the menopause. Yeah. No, I understand that. What in terms of you, well, obviously we would talk about the HRT, but other non HRT. So let's talk about like natural supplements. You walk into a pharmacy, there is a whole kind of section, an aisle of menopausal supplements, and there's so many forums online that would recommend women to take X, Y, and Z, which are natural supplements to get them through menopause. And again, I feel like they play on the kind of the stigma of being on the HRT. Tell me more about that.
I mean, there are, if you go into any kind of health food shop or natural shop or any pharmacy, there are dozens and dozens and dozens of products marketed towards menopause. Some of them are great and they are just vitamins. Some of them are slightly more problematic. So things like natural remedies or herbal remedies, or even nowadays it's the bioidentical hormones. There are some issues with them. So things like black cohosh, red clover, phytoestrogens, ashwagandha, I think is a new one. Yeah. All of those ones, they're meant to be natural, they're meant to be herbal, but there is no evidence, there's no regulation, there's nothing to say that these actually work. So just be very, very careful if you are taking any of these. If you find they're helpful, great. But if you don't find them helpful, definitely stop them. But the most important thing is with any of these things, you need to tell your healthcare professional if you are then going to have any treatment for anything else. Yeah. It's really important because a lot of these medications can interfere with other medications that you might be on. Yeah. And then talking about kind of bioidentical hormones, there are lots of different things in the press and the media about different things. Yeah. These are non-regulated. There's no evidence for them at the moment, and we are not supporting them to be prescribed. However, a lot of people will go and get them. And again, it's really important if you're on these medications to go and seek medical advice if you have any problems with them, side effects with them, but also if you're going to go on to different treatments because it will have an impact on them. Right.
And this is not the kind of the vitamins. No. So like as we refer to calcium, vitamin D, so the kind of the vitamin, I don't want to name brands, but there's certain brands that says menopause 50 plus. So those ones are okay.
Yeah. So they're normally kind of multivitamins that you would just normally get. So they're necessarily, they're not necessarily harmful. Definitely, if you are going for different consultations, definitely tell them you're on kind of over-the-counter stuff. But no, they're not necessarily more problematic. It tends to be the ones that are from health food shops. Or online that perhaps you don't always know what you're taking. Those ones can be really, really problematic.
The Instagram pop-up sponsored one.
Yeah.
Says, are you going through menopause?
Yes.
This can help you. No, I get those. Right. So the kind of exciting part of this would be HRT.
Yes.
Tell me what exactly is HRT, please.
So HRT is exactly what it says it is. So it's hormone replacement therapy. So you are replacing those hormones that are naturally occurring in your body. So estrogen and progesterone. You can also have testosterone as well. But estrogen and progesterone, you're replacing them back to their normal levels. So you're not raising the levels. You're not kind of having lots and lots of estrogen and progesterone. It's back to your normal levels. So a lot of women have real benefit from on a HRT, but it has to be the right amount of hormones at the right time for the right person.
Right. And what are the kind of different types of HRT then? So,
it is quite... When you're going through it and you're a patient or even a healthcare professional, there's so many different types and it is quite overwhelming when you think of it. Yeah. So the different types basically boil down to estrogen and progesterone, so the naturally occurring hormones. Now, you can have estrogen and progesterone together. something called combined, or you can have them separately. So as I said before, estrogen is something that normally causes the symptoms. So when you have a lack of estrogen, that's when you have the symptoms of menopause. So if we replace that, you'll have less symptoms. Also, estrogen is protective against all those long-term consequences of having the menopause. So things like cardiovascular disease, bone health, dementia, all those kind of things. So progesterone, you purely have progesterone as that kind of endometrial protection. So that protection for your uterus to stop developing complications. So if I was just to give someone with a uterus, if I was just to give them estrogen, what would happen is the lining of the womb, that the endometrium would grow and grow and grow and grow, and those cells would become atypical, so they become abnormal, and then they could develop into a cancer. Right. So when you have progesterone, we add it in to stop that from happening. It keeps the lining of the womb nice and thin, and therefore it stops you from bleeding, but it also stops you, it helps prevent against those kind of cancers.
Right.
So if you have a uterus, then we tend to give estrogen and progesterone, whether combined or separately. But if you don't have a uterus, we tend to just give estrogen.
Right.
Okay. Now, there are lots of different routes of the hormones. So when I talk about routes, that's how you take it. So most commonly you can have kind of oral, so they're tablets. Yeah. And again, you can have estrogen and progesterone. The next ones are kind of what are called transdermal, so they go through the skin, and they are patches, gels, sprays, creams. There's lots of different options. And then you can also think about having kind of implants. So that's things like the Mirena coil, or the kind of a hormonal coil. And you can also have kind of more locally active ones. So if you have any vaginal symptoms or urinary symptoms, you can have vaginal creams or pessaries and things to help. Yeah. So they're the different kind of routes. They're also ones that if you are still bleeding or still having periods, or even though if they're erratic, you can be on what we call sequential HRT, which is basically when your hormones mimic what you would normally have in the cycle. So when you have your menstrual cycle, your hormone levels change throughout the cycle depending on where you are. And so when you have sequential HRT, that mimics that. So you have higher levels of progesterone or estrogen towards the cycle. Right. You can also then have continuous HRT, which is basically a low level completely, just constantly. And they're normally for women who are either older or definitely women who don't have periods any longer.
Right. So just to clarify, to make sure that I understand this correctly, it probably goes back to one of the stigmas as well. So when you're on HRT, even though you haven't had periods for a year, let's say, because then you'll be menopausal, when you start having HRT, do you end up having your periods?
So that's a really, really interesting question. So when you have stopped having your periods, so when you're postmenopausal, so you've stopped having your periods for over a year, we tend to start with the continuous. So that's a low dose of estrogen and or progesterone. Right. With some women, we do find that their periods can come back, and they do experience vaginal bleeding. It's normally within the first kind of 3 to 6 months. If it's longer than that, then definitely go and seek help with your GP again, or your healthcare professional, whoever's prescribed it. You can still have HRT even if you're perimenopausal. So if you're still having symptoms of the menopause, but you're still having periods, you can definitely take HRT. There's no barriers to that at all. You don't have to have gone through it all, and then you can take it before you've reached that point.
Carry on having your period then?
Yeah, you can do. Yeah. Okay. And again, we normally kind of allow that until you've reached kind of 51, 52, sometimes up to the age of 54. So it just depends on where you are, your personal history, that kind of thing. It depends on how long you stay on the sequential, and then we switch you to continuous.
Right. So in terms of the health impact that it's having on your body, is it good or bad? I don't know if you can categorize it, but is it good or bad to stop your periods essentially? Or not stop it?
So in terms of kind of physiologically stop it, so everyone goes through, all people born with ovaries, they will go through the menopause. So it's important to know that this is a natural process. You would expect that if you were on HRT and to have your period, that's quite normal. So it's not bad at all. It's not good or bad. It's just something that does happen. What we want to make sure is that if you do start bleeding on HRT, if you've had a period of stopping, so if you've not had a period for over a year and you start bleeding again, that can be normal when you start HRT. But then if it persists kind of longer than 6 months, it's definitely worth getting investigated to see if there's any other cause. It could be like a polyp or something benign, but it could be something more sinister.
Okay. Thank you for that. So the important question, I think we briefly touched on this, about the stigma around HRT and how safe it is. should be worried? You mentioned there was a paper which kind of scared everyone off and said, oh, HRT is bad, it's going to give you cancer. But obviously that was not the truth behind the research, and the narrative is changing now. So who should stay well away from HRT, who is not suitable for, and what would your recommendation be?
So I think it's on a case-by-case basis. It's all to do with the kind of individual person. It's to do with their background, their family history, their kind of symptoms, but also what are their preferences and what are the risks involved. So is it safe? For the majority of women who are less than 60 or within 10 years of having the menopause, HRT is very, very safe. The benefits outweigh the risks. Right. And those benefits are for long term. So things like osteoporosis, cardiovascular health, cognitive kind of function. We do find that there has been research and there has been evidence, as I kind of previously mentioned. There was a big paper published that kind of scared everyone off HRT because they said that it definitely causes breast cancer, the massive increased risk. But actually that's been debunked and that's been disproven now. And actually, when we look at the data and the data since, there is a very small risk of breast cancer, a very small increased risk of breast cancer if you're on HRT compared to women who aren't on HRT. Right. However, that risk is actually less than if you smoke 10 cigarettes a day, or if your BMI is over 30, or if you drink a moderate amount of alcohol. So actually it's all relative. Yeah. In terms of kind of other safety things, there are people who perhaps need to have alternatives to HRT, or maybe on a different route of HRT, so things that go through the skin rather than kind of oral. Yeah. And they're for people particularly who have a personal or family history of cancers, or hormonal cancers in particular, so breast or endometrial cancers. Yeah. But also women who've had heart attacks in the past, myocardial infarction, or strokes. Yeah. People who've had blood clots. What's called a venous thromboembolism. So that's either a DVT in the leg or a pulmonary embolism, PE in the lung. So, and those women need to kind of have definitely a consultation about the kind of risks of HRT, which can increase your risk of having blood clots if you take it orally, but not if you have it through the skin. But also women who have liver disease definitely need to be cautious about the type of HRT they take. The other kind of people that we talk about HRT in are those younger women, so that women who are less than 45 who perhaps are going through the menopause and early menopause. Yeah. Those women, if they want to preserve their fertility, so if they want to carry on and have more children, then for those women, again, we need to discuss the type of HRT they're having. So HRT isn't a contraception. That's a big myth. So
yes,
HRT
absolutely.
is not a contraception. So if you are sexually active and you are kind of still having periods, there is a chance you become pregnant. So with those women, we do need to talk about contraception as well. But for those women who want to preserve their fertility, there are different types of HRT that they can have.
I'm so glad you touched on contraception, because it's similar hormones in kind of contraceptive medication as in HRT. So it can be kind of misconstrued for as a contraceptive method.
Yes, that's right.
I've seen that from so many patients as well, actually.
We actually use, there are some contraceptive pills, so the combined contraceptive pills that we actually use in patients who have premature ovarian insufficiency as a HRT. So it is completely right. They are very bio kind of similar kind of preparations, but we have to be mindful of this is not a contraceptive.
Yeah. So it's not, there is that obviously risk of pregnancy. Yeah, that makes sense. And let's say we are kind of one is on HRT. Mm-hmm. Going back to the kind of the long-term effects that we talked about earlier, the kind of the risk of osteoporosis, the weight gain, and so on. If you are on HRT, would having these kind of hormonal replacement therapy prevent you or reduce your risk of having those conditions?
Absolutely. So if you have it at the right time, so if you start HRT less than 60, or within 10 years of your menopause, then absolutely it will reduce all of those risks down. And it also helps with your symptoms, which is the majority of reasons why women have it. Yeah. If you have it over 60 or prescribed over 60 or after 10 years, there is no benefit for those long-term. So there's no additional risk that they will happen, but there's no benefit. So you won't have those kind of that reduction in risk, but you will have a symptom reduction.
Right. Okay. That's really interesting that you mentioned the age gap. So can anyone take it up to any age, to be honest? Is there a kind of the hard stop? Should you be so lucky to live to 100, would you carry on taking it till then?
So I have had patients who have been in their 90s and still taking HRT. So there used to be a thought that you should only really be on it for 5 years.
Yeah.
However, if you're still having symptoms and you still have annual reviews with your healthcare provider to make sure that they're aware of all the risk factors and to make sure that you're kind of healthy otherwise, so you haven't developed any medical problems that could interfere with your HRT, or your HRT could interfere with them, and you're well aware of everything that could happen, then there's no reason why you can't continue your HRT. Long term.
Okay.
What we do suggest for women is to have those annual reviews, to have those checkups, to make sure that this is a safe thing for them. We know that women typically take it for years, particularly if they're having symptoms. You can have a trial off it and see if your symptoms come back. Sometimes they do. Sometimes they go back on them. They go back on the HRT to help with them. It's really an individual choice. The only thing I would say is definitely make sure that if you are going to take HRT, that you have regular check-ins with your healthcare provider.
Right. And what are the side effect profile like?
With HRT?
With HRT, yeah.
So it's really interesting, actually. There are side effects with HRT, and it's very similar to how you would feel around your period, because we're replacing those hormones, so back to that level. So some women, when they have their period, would get kind of headaches, mood swings, breast tenderness, all those kind of things, and that happens with HRT, or can happen. It's more likely to happen when you first start HRT, but if it does happen and it's becoming more problematic, or you're getting a bit fed up with those kind of side effects, you can either change the route. So if it's oral, you can change to like a patch or a gel, or you can change the type. So there are different types of synthetic progesterones in particular that we can change to that have a better side effect profile. The other thing to consider is, as we already touched about, is that with HRT, some HRTs can make you bleed, which can be alarming. Yeah. So I'm talking about kind of vaginal bleeding. So it's not necessarily a period, it's just called a withdrawal bleed. So it's a physiological process because of the hormone levels. That can happen when you start HRT. What we try and tell women is if it happens when you start HRT, that's normal for the first 6 months. After that, definitely not normal. You need to go and see someone. And it may be that you just need to have a full MOT just to check out if there's anything more sinister going on. If not, then they might change the different dosage or the different type of hormones. If you're on HRT long term and then suddenly develop bleeding, that is definitely a red flag. That's definitely something you need to go and see your healthcare provider about, because that is not normal.
To suddenly just start having
that. Suddenly start bleeding.
That makes
so
sense.
If you've been on it for 6 months or more and you've not had any bleeding, and then suddenly develop bleeding, definitely go and see someone.
Yeah. So side effects, I'm assuming, would happen in the early stages of a treatment. Yeah. Anything else, if you've been on it for like 3 months or so, 6 months, and suddenly start having, that's more than just a side effect.
So if it's over 6 months, definitely that's not normal. If it's within those first 3 to 6 months, that's abnormal. But we normally, when we start people on HRT, normally what we do is we review them at 3 months anyway to check how they're getting on, any side effects and things like that. So it's a good kind of stopping point at that point.
And don't be I suppose the message from this is that don't be disheartened if you don't get on with it, if you experience side effects. As you said, there's so many different types, and there are obviously more specific. So for example, if you're having vaginal dryness, then I'm assuming you will have the topical treatments for it. So it might be that you don't really generally need kind of systemic support. So when we talked about kind of different kind of routes of HRT, there are some women who don't like the idea of taking hormones systemically, so taking a tablet or it affects the hormones all over the body. And one of the common things that we see is that particularly women who have problems with their vaginal dryness or vaginal symptoms, so that's things like dryness, that's problems having sex, that's kind of irritation, that feeling of kind of grittiness down there, that's how it feels. And so with those women, they don't have to have a systemic hormone for that. And actually we've noticed it's actually better to have a vaginal estrogen. So that's a estrogen that's applied. It's normally a cream or a pessary that's inserted into the vagina or around the vagina that can then help with those kind of symptoms. They are very, very safe vaginal estrogens. They're not absorbed systemically. So ladies with breast cancer, ladies with liver problems, all these people that have problems who can't take HRT can definitely take vaginal estrogen. Right, that's really reassuring. And just to briefly touch upon the I suppose some patients who are already on HRT would be aware that there is a lot of stock issues in terms of accessibility to HRT. My community's my background is community pharmacy, and there was so many kind of months, years where patients really struggled to get their kind of regular HRT patches. What would your recommendation be when there are kind of stock availability? So once you find the medicine or the type of patches that actually works for you, and then they go out of stock for months, what would be the alternative?
So it's really interesting you say that, because there are, when you start on HRT, you're normally given a brand, or you're giving a certain type of estrogen and a certain type of progesterone, and they can be from different brands, but they tend to be the same. If you are finding that you're having problems with that certain type of HRT, what you can do is kind of make a switch with your healthcare provider to switch onto something very similar, and they should have a similar hormone kind of level and a similar side effect profile. If there are problems with that, then you can change to different routes. But what we normally say is, once you've stuck on something that's good for you and it's taking into account your risk and your profile and also kind of your lifestyle as well, because if you're a swimmer, you might not want a patch and things like that. So with any of those issues, then we tend to keep on the same route if it works well for you.
Interesting. And what would someone do if they didn't want to be on HRT? What would be the alternative? We mentioned not to go near any of the kind of herbal things that is not evidence-based. It might be that it's contraindicated, so they're not actually suitable for having HRT. What would they do then?
So there are loads of alternatives that you can have if you're not suitable for HRT, or perhaps you're worried about going on HRT. There's lots of things you can try, and with a lot of good evidence as well. So things to kind of try that are non-medication related are things like CBT, cognitive behavioural therapy, and hypnosis. So they've got really good evidence behind them to reduce, particularly for hot flushes and night sweats. So we know that particularly with CBT, it can reduce symptoms by about 83%.
Wow.
Which is massive. And so you can, and again, you can have this in combination with HRT as well, or not if you're suitable for HRT. So CBT is or hypnosis are really good options. Other things you can try, so they've got limited evidence, it's things like acupuncture and things, but there's limited evidence to support that. If we're now talking about kind of medication wise, there are loads of different medications. And again, your healthcare provider will be able to kind of prescribe the right one for you and the right one for your symptoms as well. So there's things like clonidine, there's things called gabapentin, which is a typical painkiller. You can also have antidepressants. So the ones called SSRIs or SNRIs. So they tend to be prescribed for patients not just for mood, but they can also help with those menopausal symptoms as well. But the most important thing is for any of these things is that it's the right one for you and your symptoms at that time.
Yeah. Okay, that's really interesting. So if someone's listening and they are really interested in pursuing HRT treatment, how would they get this help? Where do they go?
So the first protocol would be so educate yourself, but also go and seek help from a healthcare professional. So either that's your GP or a menopause specialist or an online pharmacy. I think there's a lot of information out there, and like I said before, there's a lot of options, and it can be very overwhelming. Yeah. So it's really important that you're aware of the different options that might be suitable for you, and then you seek the help from those people that then can advise you on the best one for you. The other thing is you can, on the NHS, you can get a HRT prescription, and you can actually have a one-off prescription cost that you can have unlimited HRT products. So there are options available for you should you wish to go kind of down the NHS route.
I'm glad you mentioned that, because obviously the prescription kind of costs are not actually cheap. So, and if you're having this as a regular treatment, that could be a factor in some people. I've been in that situation in the past where I'm like, oh, actually, I'll just put up with the pain and not get a prescription treatment because it can be very costly. So I'm glad you mentioned that. So this is the prescription prepayment specifically for HRT.
Yeah, so it's available in England at the moment, but they are looking to expand it to the rest of the UK.
I see. Okay.
But yeah, so especially because you might have different products. So you might have a vaginal cream, but then you might have a patch, but then you might have, a tablet if you have estrogen kind of orally, but you might have a patch of progesterone, but you might have a vaginal estrogen cream. So there's lots of different options, and it can be very, very expensive.
Yeah.
So if you have that one-off cost, actually for unlimited stuff, you can trial and error.
Yeah, that makes sense. I was going to kind of bring this together and say, what would you recommend to someone who is feeling overwhelmed? But right now, I'm feeling really overwhelmed by all this information. So what would you advise me?
I think the most important things that I want to get across is that you're not alone.
Mm-hmm.
So there are women out there who think they're completely on their own. This is the only thing, they're the only one to go through all these symptoms. They're the only one that's affected. But actually, lots of women go through very, very similar things. And to go out there and realize that you're not alone, there are support groups and there is help available for you is key. The other thing is that if you are going to seek treatment for kind of symptoms and things, that you get it at the right place, you get it at the right time for you, but also you seek that help when you need it.
Okay, well, thank you so much for that, Charlotte. Okay. Honestly, that has been probably one of the best discussions that I've had, and obviously this is such a close topic to myself as well, being a woman as well, and having a daughter as well. And I would love to, for the next generation, to also provide that education for our future. Thank you so much for that. Really appreciate you joining us and shedding light on the whole menopause topic. Really appreciate it. Thank you.